So Medic 14, Engine 11, respond to a 47-year-old male, syncopal episode. He is a diabetic.
May 14's on scene. Hey, what happened?
Thank God you're here. This is my brother-in-law. He's recovering from a recent surgery on his shoulder, but that seems to be going fine. He's diabetic. He was just having lunch. We worked together. He was having lunch, and he sat up. He got a little pale, and he just went right out.
Huh? And you said he's a diabetic?
Yes, ma'am.
Alright. And when was his surgery?
It was about 3 weeks ago. He's been milking it ever since.
Was he complaining of anything before he went down?
No, he just asked me to bring him some Cokes. He had chips and Snickers and everything else, but...
And normal right before you called?
Yeah, everything else has been fine.
Only medical problem is diabetes?
That's correct.
All right, I'm gonna also get a blood sugar and see what that is. Do you know if he has an ID or anything like that? We can, and what hospital?
Oh, I've got all of his information if you want it.
Cool.
Blood sugar is 187.
All right, thank you. Hey, Robert, can you look at me over here? No? So we're gonna get him in the truck as soon as the truck gets here. But of course it's not his blood sugar, and it looks like he eats a lot. How's his lifestyle?
Oh, I never see him without a bag of chips and a soda, and
Really?
when he's not running his mouth, he's stuffing it with nachos.
Gotcha. Any heart problems that you know of?
No.
Just the diabetes?
Just the diabetes.
Does he take pills or insulin?
He does take insulin.
And what meds, or do you know what meds he's on after this surgery? He had no radial pulse initially, so that's why I laid this back. Still haven't got one. Blood pressure is 84/40. Heart rate is 57. And as you can see, he has some snoring respirations that do seem to kind of resolve themselves when you open up the airway. But not very responsive as far as like mentation, but he does respond to verbal and painful stimuli. So, it's a couple different things that can be going on, so think about it, and then I'll give you the rest of the information later. And here's your 12 lead. I'm gonna take a look at this and discuss some pointers on here. But as you can see, the rate is 63, so a little bit up from where we were. There's a P wave in front of every QRS. The QRS is narrow. There's a T wave. So this is a sinus rhythm. Rate of 63, a little bit better than where we were. You do have inverted T's in V1. Looks like negative deflection in 3, so maybe some left axis deviation, and possible poor QRS progression in your precordial leads. The other thing that we can take a look at is how far those T waves are from the QRS. So maybe a shortened PR interval, but this is a slow rhythm, so we want to see if this is also a prolonged QT. And our way to know that is this QT and QTC at the top, but as you can see, there is a scale, and male and females are different. So as you can see, the males are about 10 lower than the females when it comes to the QRS, QTC milliseconds. The male is considered long at 450. The females are considered long at 460. So if we take a look back at this 12 lead, this one is 470. So according to that scale, this is a prolonged QT interval. So the quick rule is the QT interval should be less than the R to R. So the best places to look for this is in V5, V6, and lead 2. So the better lead is 2. So you'll find your QRSs, mark the Q, Then you'll mark the other Q. And your QT starts at the beginning phase of your QRS. So not right at that J point, but just a little bit close to that. So that's where you'll put your first dash, and then you'll mark the end of the T wave. Right there. Yeah. And as you can see, that is a little past half, right at half, but a prolonged QT. So like I said, prolonged QT on the quick rule is it should be less than half of the R to R. But this is also your definitive way of knowing if it's a prolonged QT, if you can remember those numbers. Anything above 150 basically is a prolonged QT, male and female, and this is at 470. And as we know, prolonged QT can cause syncopal episodes, as well as putting you into some lethal rhythms, including torsades, and causing sudden death. So now that you have this information, the 12 lead, and you've watched the video, I want you to pause this and discuss amongst yourselves the working diagnosis and the treatment plan. Well, I wish I was a fly on the wall to hear all the discussions that this video brought up, but I would just use my imagination for now. So I hope during this discussion you kind of methodically thought through it and was being the great clinicians that I know you can be. So of course, when it comes to a working diagnosis with syncope and altered level of consciousness, there could be a plethora of different things. But there are some things that this video should have ruled out pretty rapidly. So the big things we look at is respiratory, cardiac, neuro, metabolic, psychogenic. So when it comes to respiratory, I think we ruled out a lot of things up front. Open airway, breathing normally, the snoring respirations go away with positioning, O2 sats is 98%. Think we can check those boxes and not say that's our primary cause. Then, of course, you also knock out your ABCs with that. Well, at least your A's and your B. Then you go to the cardiac. Can't really rule that out based on the 12 lead because that causes syncope, but would it keep him this way? And then you got that blood pressure, so I'm sure you thought about it. Hopefully that's there. So it's going to be in the back of all of our minds if that's the root cause. But neuro, are we able to even get a good neuro exam on him? Didn't follow commands. Billy Bob rarely does. But nothing is really sticking out as a stroke. There's no trauma, but it's one of those cardiac things. Can't really rule it out completely, but I wasn't able to really rule anything in just yet. When it comes to the metabolic, man, that encompasses so many things. And that is exactly probably where I'd kind of go. Now, you can check a temp. We're going to say the temp is normal. This probably isn't sepsis, but with the recent surgery, definitely could be something and should be something that you were thinking of. When it comes to the psychogenic, hopefully somebody, said something about that. But anyway, the vital signs kind of make that jaded paramedic kind of sit down and not have much to say about it because, hey, you can't fake vitals, right? You can't fake being diaphoretic. There's certain things that you just can't get around and call this a mental health issue. But when we look at this call, and I hope you was able to think through a lot of different things versus just going down one train or one road. But this was kind of a mixed bag. And I would hope that you wouldn't toss up your hands, and I hope your treatment would definitely be Trendelenburg and fluids, and let time be your guide. But we're looking at what is a vasovagal response, and the pain meds that he doesn't take regularly kind of hit him a little harder than he wanted, and put him out. So the combination of the pain meds and a vasovagal response, we do have that combination there, and that was the root cause of this. So it just so happens that the prolonged QT was something I just kind of wanted to touch on, but wasn't the actual reason that any of this happened. All right, so thank you for watching. Hope this was entertaining. And if not, send me an email if you have any suggestions, comments, concerns, other things you found that it could be this or that or something else outside of the box. Yeah, draw me an email, let me know. Then hopefully it can be a discussion amongst others, not just your crew. All right, enjoy the rest of your week.